All right. So I will do a few introductions of who is on your panel today. We have Dr. Aaron Haug. He is a neurologist and movement disorder specialist at Health One Neurology Specialist in Denver. He completed his neurology residency and a movement disorders fellowship at the University of Colorado. This included a year as chief resident. In his clinical practice, he focuses on Parkinson's disease, tremor, and other movement disorders with expertise in both medical management and deep brain stimulation for the treatment of those conditions. Outside of the office, he likes to spend time with his family, play ultimate frisbee, and follow Colorado Rockies baseball. So let's join him, welcome him to the panel. And then we have Carrie Friedman, who I think many of you know, who is a licensed clinical social worker. She's been a part of the Parkinson's Association of the Rockies since 1999. Carrie is the Patient and Family Services Director and works with constituents and their families when newly diagnosed, have a change in their health status, and when something urgent happens to them. In addition to being with PAR, Carrie worked with the University of Colorado outpatient neurology and palliative care team for 14 years. Recently, she transitioned to private practice for people dealing with chronic illness. Her passion is helping those in the Parkinson's community. So let's give a warm welcome to Carrie. And then our third panelist is Jessica Turnage. She is a registered nurse, and she's been a nurse for 23 years. Prior to her hospice career, Jessica was an ICU registered nurse with a focus in neuro level 1 trauma. Jessica even trained to be a flight nurse until the death of her first husband. After his death, Jessica found herself on the hospice path. With her personal journey, Jessica has made it her passion to help educate families and loved ones so that they can have the tools that they need to make the right decisions for them. She's now been a hospice nurse educator for 7 years, so let's welcome her. All right, well, thank you so much for being here today. We're going to start in with some of the panel questions, but before we do that, we'd like to just get a little bit of a sense of who's joining us in the audience today, because this will help the panel to tailor their responses and questions. So could you please raise your hand if you're a care partner for a person with Parkinson's who has been diagnosed 0 to 5 years? Okay, thank you. How about a care partner for a person with Parkinson's diagnosed 5 to 10 years? Okay. And then finally, for care partners of people who were diagnosed 10 plus years. Okay, thank you. Well, it looks like we have a pretty even mix here today for that. So our first question we're going to start with today is about navigating the relationship changes that can occur during that progression of Parkinson's disease. And we thank you ahead of time. Many of these questions were received from you as participants, and this was a question received from one of you. So Carrie, we'll let you kick it off here. How do you talk to family about the progression of Parkinson's?
That's a good question. So when you find out that you have Parkinson's, how many of you were told, you have Parkinson's, I'll see you in 6 months? How many did they explain to you what Parkinson's was? Not that many. Okay, so navigating through the system. That's what I'm here for. I wear lots of hats through PAR, and I will get calls from people when they're newly diagnosed, when they're coming out of the doctor's office, and they have the capability of saying, I need help now. So what I do is help you, be an advocate for you to make sure that you're seeing the right kind of doctor. So movement disorders doctors like Dr. Haug, and who specialize in Parkinson's. So helping you go, thank you, see other people. That's how I would help start with that. And then we can go from there. So I always say that our brains and our hearts are separated for a reason, because if they're together, they're on overload. So if you are thinking about what is this disease, what do I have to do for it? And then not talk about that, and then not have the feeling of how sad it is. Know that it's okay to separate those, and you navigate by talking to your provider about getting another doctor who will specialize in Parkinson's to advocate for you.
Okay, thank you, Carrie. And as a follow-up, this next one's for you as well. For how to ask and accept help, especially when the person with Parkinson's is reluctant for that help.
Yeah, that's really hard. How many of you have a hard time accepting help yourselves? Yeah. So I know when Milena was talking, she was talking about that, and you have to take care of yourself first, right? So when you go on an airplane and the flight attendant, not, so you have to be politically correct when you say they're flight attendants, they say, put the mask on yourself first and then the other person. And that's what you have to do, is take care of yourself. And then if the person says, I don't want any help, I don't need it, you say, I need the help. And so turn it around that I need help. Use the I statements instead of you need to get some help, because that puts the person who have Parkinson's on the defensive. So say, I really need some help, because in order for me to help you stay in the home, or if you need to go on to another assisted living or something, I need to have some help for myself.
Thank you. All right. So Dr. Haug, we'll let you start with this one. What do you wish that patients you see or their care partners would share with you that maybe you find out they're reluctant to talk to you about?
Yeah, it's a good question. Thank you. And thank you all for being here this morning. I will answer the question, but I'm going to vamp for just a second. I like Milena's slide towards the end about you all being superheroes here. I think that is not an overstatement. My kids were watching this movie this morning called Captain Underpants. And I thought, this is a made up superhero, and I'm going to go be in a room full of real superheroes. So I appreciate you all being here this morning. In terms of how to prepare for your doctor's visit, I think that there are two extremes that are not helpful. One is you come in at your 2, 3, 6 month follow-up visit, and you say, I haven't really thought about anything that I want to talk about today. Let's just sort of brainstorm. That's less than ideal. The other thing that's less than ideal is on the other extreme, which is having a spreadsheet of your 15 most bothersome symptoms charted day by day for the last 6 months. I think that the golden mean somewhere is to think of the 2 or 3 symptoms that are bothering you the most. And I think one of the other points that Milena made is well taken, which is that it can be hard to know which symptoms are related to Parkinson's. And so learning through events like this, through other resources, like through the Davis-Phinney Foundation, I think being aware of, oh, wow, this is on the list of things that can happen in Parkinson's. So talking to my Parkinson's doctor makes sense here, is a good idea. So then having 2 or 3 things that you think, gosh, this is bothering me enough that I would take a referral, or I would start a new medicine, or adjust my medicine for this. The role that your neurologist has is particularly the ability to make referrals and prescribe medications. And so I want to know, how are you doing? But I also want to know what action steps are we maybe going to be looking at. And so the principle of beginning with the end in mind of, gosh, I'd really like to walk out of here with less medicine or a new medicine. If I know that early on, then that helps to guide how we're going to have our visit.
Wonderful. Thanks for those tips. And Jessica, what about you as a nurse? What are those things you wish people would talk to you about that maybe they're reluctant to?
Honestly, for me as a nurse in hospice, we hear very frequently when people finally come on service that they wish that they knew about the services sooner. A lot of people are very leery and scared of the bad H word of hospice. And there's a lot of myths and misconceptions around hospice. And a lot of people don't know that you can actually be on hospice for months, even years in some cases. But all of the support that you get really do help people live longer on hospice. And so just even having the discussion is something that's very, very important to be open to, because a lot of what we offer with our equipment, with medications, with symptom management, especially in collaboration with your providers, can really help improve quality of life. So I think just being open to hearing what hospice can do for you is a crucial part of your loved one's care.
Thank you. All right, so the next question, again submitted by a registrant for the conference, is we're going to talk about this topic of differentiating between aging and progression of Parkinson's disease, because there can be some overlap there. So the question is, what subtle signs should one watch for that indicate possible progression, and how are those signs differentiated from everyday aging? And Dr. Haug, let's start with you, and then Jessica, maybe you can follow up with that as well. And I think you guys are going to need to speak loud to get over our, our competition here.
Sounds like a party next door.
I know.
It might be Captain Underpants. I
was
don't know.
thinking, I know, he's coming here. Or she.
So this is a question that doesn't have a cut and dry answer. One of the ways that I will sometimes describe Parkinson's is that it's kind of like getting older faster. The strength loss, coordination loss that can occur as part of normal aging gets accelerated in Parkinson's, with the added on things of tremor and so many of the motor and non-motor symptoms that we're familiar with. And so in terms of, well, is what I'm looking at normal aging or is it part of Parkinson's? I think that if it's one of the things that's really bothering you, ask me, ask your neurologist, your other healthcare team members, well, I'm dealing with this. Is this something that's aging or Parkinson's or both? And is this something that we have to accept, or is this something that we can do something about? So much of Parkinson's is living out of the serenity prayer, the courage to change what we can, the serenity to accept what we cannot change, and the wisdom to know the difference. As your healthcare team, part of what we're trying to provide is some of that wisdom of, well, that's one that we've got to accept. This is one that, oh, there's a medicine. We could increase your medicine. We could send you to physical therapy. Maybe it's time to have you meet with Carrie or someone from palliative care or hospice. And so I think that that is how I would frame the answer.
Thank you. And Jessica, do you have some additional thoughts?
I do. So for me, in regards to hospice care, by the time that we start our care, it's usually beyond, when you're beyond the point of therapy working anymore. The Parkinson's has progressed to where now you're actually having a lot more physical symptoms. And so my answer is kind of two-part. So physically, we deal with things, and I did put we put some of these on your tables. These are what will come with advanced Parkinson's and what makes you eligible for hospice care. So some examples would be if we have problems with breathing, shortness of breath at rest, we can mitigate those symptoms usually with low doses of morphine or oxygen. There are certain various oxygen options that we can also provide in hospice. Under Medicare, all equipment and all comfort medications are covered 100% under the benefit. So these are not things that you pay for. There's other symptoms like losing the ability to walk. So for that, we would bring in equipment to help with that piece. There could be things like high anxiety related to losing control of your body and also with the pain. So we can treat those things with anti-anxiety medications or even antidepressants in conjunction with your primary care doctor. When Parkinson's progresses, there is effective swallowing called dysphagia. And so with that, there's things like modified diets, there's risk of aspiration pneumonia. Those are things that we can help treat the pneumonia, antibiotics. So we try to mitigate the physical symptoms that are happening. Obviously, you would continue your medications already prescribed before hospice, like your carbidopa, whatever that is helping to control your tremors. But we would just work in conjunction with your providers for the physical symptoms. And then also in hospice, hospice consists of a whole team. So it's not just a nurse dealing with clinical things. You have a social worker, you have a chaplain. These extra existential support systems are really to help you as family members and caregivers, but also your loved one with Parkinson's, with all the psychosocial things that are happening. Loss of independence, the role changes. If it's your parent that you're caring for, that's a role change for your parent. Things like just that grief loss. And with all of that, problems with being able to walk or swallow comes social withdrawal. You know, you're going to find your loved one not wanting to go to a restaurant because it might be embarrassing for them. And so these are things that we walk the path with you on. So addressing not just the physical, but also the psychosocial piece is very, very crucial and something hospice does.
Thank you for providing that information on that whole team. That's really helpful. Okay, we're going to shift to our next topic now, which is managing medications. And so, Dr. Haug, this first one will be for you. How to manage, a registrant question was, how do we manage medications, especially when there's a change in those medications? And what do you do if you see side effects that seem to conflict with other medications, or if there's an issue?
Yeah, so this is kind of the meat and potatoes of being a neurologist, is managing medications for Parkinson's and other neurological conditions. So I think that it kind of is a variation on the theme that we've started here, which is, well, please tell me what symptoms are bothering you. If you're having more tremor or more balance difficulty, those are going to lead down different paths. The medicines mainly can help with stiffness, slowness, and tremor, not so much with balance, where it's more of a use it or lose it, exercise, physical therapy. Those are the interventions that are going to be more helpful. I had another train of thought that I lost, just so I can normalize that behavior that I'm sure happens to you and your people that you're caring for. Boy, it's not coming back either. So there's a note here about talking about early PD versus advanced PD medications. I think that there are strategies that differ even from one neurologist to another about, should we start levodopa, carbidopa, levodopa early? Should we start something else first? And that's something that it might be helpful to, well, it's important to have an open conversation with your provider. But if you're feeling like you're having questions that aren't getting answered, it might be worth having another opinion from another advanced practice provider, another physician. It's important to have a clear and open line of communication with your prescriber, because what I try to do for you is going to be guided a little bit by what I see on your physical examination. But I can have two people that come in back to back with the same tremor, and one of them says, oh, yeah, no, that doesn't bother me. And the other one says, oh, well, I can't play guitar, I can't cook. And so it might be the same tremor, but what we do about it is going to differ depending on how much it is bothering a person. When my train of thought came back. So the different, thank you. So the goal of medical management and really complementary and alternative approaches to Parkinson's as well is to maximize function and to minimize side effects. And so if the symptoms that you're having are maybe a little bit of a nuisance, but not bothering you as much that you would want to take a medicine for it, then I'll say, okay, well, we'll expectantly manage that. We'll keep an eye on it. And if it gets to a point where it's worth taking another pill, then we'll have the conversation again. So that's, let's see how to balance out discussing. So there's a point here about let's talk a little bit about carbidopa, levodopa. So this is the gold standard medication for Parkinson's. It tends to be the most helpful medicine for the physical symptoms of stiffness, slowness, and for the 2/3 of people with Parkinson's that have tremor, also for the tremor. And so what do we need to do about carbidopa, levodopa to make it work as well as possible? There are these myths and misconceptions about carbidopa, levodopa, and I'll speak to those. One of them is, does it matter when I take my carbidopa, levodopa relative to meals, and particularly high protein containing foods? The answer is, for some people, it makes a big difference, but that tends to be people that are more advanced in their Parkinson's. People that are in an early or even moderate stage of Parkinson's might neither notice an impact of taking their medicine too close to food, nor really feel that there's this kicking in and wearing off pattern, on and off fluctuations that there's a lot of press about. Part of the reason there's a lot of press about it is that some medications are approved specifically for motor fluctuations. If I have someone who comes in and says, do I have on and off periods? Then my answer is going to be, no, you don't. You would know if you had on and off periods for the most part. And so in earlier stages, there's less likely to be those motor fluctuations, and it's less important to worry about taking the medicine exactly by the clock and separated from meals. And I think that can be a relief to people and their care partners to hear that some people are read the Riot Act from day one and say, you need to take your medicine 30 minutes before you eat, 60 minutes after you eat. I think we can loosen the reins a little bit on that, especially in early stages of the disease. So take that under advisement. And one other thing I will say about levodopa is that it's absorbed not in the stomach, but in the small intestine. So taking your medicines with a full glass of water, as opposed to just a sip or even dry swallowing the medicines. If the carbidopa, levodopa is just sitting in your stomach for an hour, it's less likely to be helpful. Whereas if you drink it with a full 8 or 12 ounces of water, that may be helpful for other things like constipation and lightheadedness to get some of those fluids in. But the medication is absorbed in the small intestine. And so getting the pills washed on into the next part of the GI tract can be helpful for a lot of people.
Thank you. This is not on here, but I know my mother-in-law has Parkinson's, and a question that she brings up frequently is, if I forget my dose, should I just double up on the next dose? What should I do about that?
Usually not double up. If you forget it by an hour or two and your next one's still several hours away, I would say probably go ahead and take it. But if it's now, oh, this is my 6 o'clock dose and there's my noon dose still sitting there, I usually would not recommend doubling up, because this is a medicine that can have peak side effects. So especially people that are more moderate or advanced in their Parkinson's, if they double their dose of medication, they are more likely to have the levodopa-induced dyskinesias, the wiggling, fidgeting movements. And people even in an early stage are more likely to have other side effects from a double dose, like having nausea or lightheadedness. And so if you remember it a few hours later, you can maybe take it then, maybe push the next ones back a little bit, but typically don't double up.
Thank you. Okay, so moving on to our fourth topic here is planning future care. And the question is, and Carrie, we'll let you start with this. how or when do you know how to involve an in-home medical assistant? And then Jessica will let you follow up with that.
Okay, first I wanted to say from the talk earlier that there's another, Every Victory Counts through Davis Finney. They now have a huge a book about for care partners. So that's another thing that you can look at. And also when there was a question about, can you have home health when you have palliative care? Yes, absolutely, because you're doing everything you can to help the person. So the question was, let's see.
How to involve an in-home medical assistant.
Okay, so you'll know, you know, when you think that if the person needs home health, meaning a nurse, a CNA, PT, OT, speech, then you talk to your neurologist or primary care doctor about if there's a change in the health status, then they will, then insurance will cover it. So let's say there's a fall, and maybe you broke your wrist or different things or changes in your health. If you were sick, had pneumonia or something from swallowing issues, then they will give you home health. So some people, because I get calls a lot that my husband is in rehab right now and I don't know what we're going to do when he goes home. Well, the social worker case manager should make the referral to different agencies to get you help at home. So that's home health. And then, so people always wonder what's the difference between the two and are you going to talk about the non-medical or do you want me to?
Okay.
Okay, go ahead.
So home health is something, as Carrie mentioned, is covered by your insurance benefit, but it's a limited extension to rehab. So it's physical therapy or a registered nurse has to be doing some kind of plan within a care plan. But once you meet the goal, therapy stops. So it's not something that you have for quite a long time. When you get to the point where the disease has progressed to where that loved one really needs a significant amount of help with dressing, bathing, feeding, activities of daily living, and you as a caregiver are just exhausted or you can't do it by yourself, that's when it would be a good idea to reach out to a company like Home Instead or one of those home care companies to hire private care. So non-skilled care are caregivers that come in that can assist with minimal. So sitting or helping to clean. They might be able to set up food, but they cannot feed. So it's important to ask the company that you call, what exactly can these caregivers do? They also, some of these companies offer private duty nursing that you can pay for and hire privately, who can do obviously more things. It's within the scope of a nurse to help with medications or do wound care, for example. So with hospice, we frequently partner with those companies because hospice is not in 24/7. We have CNAs, a certified nurse assistant, who will come in a couple times a week to help with bathing and showering and providing incontinence supplies. But what do you do outside of that hour twice a week? You need to have somebody else there to help. And that's usually private paid though. Skilled medical care is more the home health and hospice CNA or nursing.
Yeah, a lot of times people use both, piggyback with that she's saying that, because you're right, when you think you have hospice that's available 24/7, they're not there to give you a bath 24/7. So you have to know that. And a lot of people then hire non-medical care to come in and do those things. So, you know, take advantage of those different resources that are out there. It can be expensive. If you have long-term care insurance, that can help too. But there's usually a wait period before that kicks in. So you'll need to talk about doing that sooner, more like in palliative care. And with palliative care, we also provide so many resources to help. And with advanced directives, we can help with that too. So, yeah.
Well, and as a follow-up to that for both of you, so you've mentioned all these wonderful resources. How do you suggest people kind of incorporate that team? So you've talked about a team approach here that can get overwhelming with all the different pieces.
Yeah, and so in palliative care, because I worked for 14 years at the university, and we each had different roles but we overlapped a lot. And a lot of times the first time you go to palliative care, it's overwhelming. So we give you a little bit at a time, and then they can follow up with us. And so some people need a chaplain, and to do spiritual, reckoning. Doesn't mean it's a religious thing. You can be any religion or not at all. They're there to help you spiritually. Social work does more of, wears lots of hats. And one of them is also doing emotional support. So if Milena, when she came in and her husband were deer with the headlights, I wouldn't give them as much information at the time, but would follow up with them and then advocate for you to provide resources along the way. So when palliative care, like she mentioned earlier, can start on day one. When you're diagnosed, and to give you resources for down the road if you need some help. So when you're really struggling, reach out to any member of the team. And we're there for you.
Great. Jessica, additional thoughts on that?
Yes, I was listening intently to Carrie, so I need you to repeat that question.
Really, from your standpoint, when you see all these different components of medical, non-medical, how do you help people to incorporate that whole team?
Okay, so the first thing that happens when you sign on with hospice care is we sit down as a team with you to discuss your goals of care. We want to know where you are in the journey, what you need help with, what do we need to incorporate. Same thing Carrie mentioned, our social worker has resources and so does our chaplain. So we're going to sit down and find out what you need to make this successful and to keep you home as long as possible. And so we'll incorporate and recommend, okay, maybe non-medical will help relieve some of that burden. Maybe we need to utilize the respite benefit under hospice to give the caregivers and loved ones a break for 5 days and something like that. And so when services continue, there's ongoing communication and collaboration with everybody involved. So we're going to communicate with the non-skilled home care, and they're going to let us know how it's going on their end. If any changes need to happen, we're going to be discussing this as a communication with all of you, with your loved one as well, because we want to know as a whole group what's working, what's not working, what do we need to implement or change. And also, I'll add, the registered nurse will be in close communication with your providers on, they know your history. Maybe they're talking to the neurologist. They want to know, we're not just going to come in and change medications. We're going to talk to your doctor to say, here's what's happening now. And they'll give the recommendations or the orders. And that's always in collaboration with the families and the patient. So a lot of communication.
Great. And Milena brought this up this morning, this idea of palliative care, hospice care. You've heard a lot about some of those differences, but I think now let's bring it full circle. If you could just do, Carrie and Jessica, a definition of the difference of those two, just to kind of solidify that for everyone.
Okay, I'll start with palliative care, and I'm going to read something, even though I've done this for many years. This is through the Mayo Clinic, and it's palliative care is a specialized medical care that focuses on providing relief from pain and other symptoms of a serious illness. It can help you cope with side effects from medication treatments, and the availability of palliative care does not depend on whether your condition can be cured. So what that's saying is that you're there for quality of life. So to help you as a team, what is team? So in palliative care, you're going to have your doctor, your neurologist, the social worker, the chaplain, a psychologist, the nurse. And then we do everything in different phases. So one thing that we also do is advanced directives. So people, we all should have an advanced directive. How many of you have your advanced directives? Some of you who don't, because you think, oh gosh, that means that I'm going to die tomorrow because you're talking to me about it now. Well, no. And you know, with Dr. Haug, I was listening about some patients come into his office. They want to know everything. Others are like, hey, I'm fine. I have a little bit of a tremor and I'm architect in it, and I need to do things to keep my hands comfortable so I can don't have the symptoms. Then you have somebody else that says, hey, it's no big deal. So in palliative care, we start where you are at. So we start where you are at. So sometimes people want to hear so much information. I have a lady I'm working with now who looks and does all the research on her condition. And then you have to tell them that, you know, don't do Dr. Google all the time, because Dr. Google doesn't have the right information most of the time. So there's certain websites that you can look at too. So palliative care is about quality of life. And so you can still do things to make your life continue to be good. So you're doing interventions. And so then there's a difference between palliative care and then there's hospice care.
Thank you, Carrie. And I also printed these, and I see some of you looking at them already. It's a side-by-side comparison of hospice versus palliative, what's covered, what's not. This is printed from the NHPCO, so the National Hospice and Palliative Organization. It's important to mention that palliative care is also based on what your insurance plan says. So some of the visits will probably have copays, but these are things that when you're looking for a palliative program, they're not all the same. They don't all offer the same. In general, it is a nurse practitioner and a social worker. Some of them have chaplains. But they do, as Carrie mentioned, works with your specialists, your doctors, when your goal is to still pursue curative or therapeutic treatments. And it's not limited to a prognosis. So like they mentioned, it's important to see about starting that day one. Really, the goal of palliative is to manage a symptom so that you can continue therapy and curative treatments. We have a palliative program as well, and it's important to know that that is also the first step before hospice, not all the time, but most of the time. And the curative no longer is an option, and the disease has progressed beyond the point of curative or therapy being able to help. And the symptoms get to a point where the quality of life is not fully managed by just palliative alone, because it's not a 24/7 service. Then your doctor may recommend hospice as the next step. And it doesn't mean that you're dying tomorrow. It means that your disease has progressed to the point where on those sheets I passed out, we know that you're in that 6 to 12 month prognosis. And we also know that these symptoms are going to increase as things change. With hospice care, it's 24/7 support, meaning that at 2 a.m, if there's a pain crisis, you can call and a nurse is going to come out and work with the physician on getting that pain managed, getting medications in the home so we can have them available to manage you quickly. The other piece of hospice versus palliative is that where palliative may have copays, hospice will not, because hospice is covered under Medicare 100%. The other piece too is that with hospice, the goal is to keep you out of the hospital. And that's not necessarily the case with palliative, because it is more of a specialist type role. And if you're having an acute event, the nurse practitioner, social worker, whomever will likely recommend you go seek aggressive acute care, like is in the ER. In hospice, we avoid the emergency room with the resources that we have. That's the last thing that somebody wants when they're progressed to the point of Parkinson's and wanting to avoid exposures to everything that the hospital has in there. But also, the goal is to keep you at home.
Great. Well, we are going to open it up for questions. We have about 15 minutes of questions. So if you've been jotting things down during this excellent presentation, please raise your hand. I know we'll have someone going around with a microphone. I'm looking for the person going around with the microphone. Let's see, because we want to be able virtually for people to be able to hear the questions as well. So we'll get a microphone. And while we're waiting on that, let's just thank our panel for sharing their wonderful expertise. That was fantastic.
You know, there was one question that we didn't get to, and while we're waiting, is how do you know when to have your loved one move to an assisted living? And I've had a couple people that I've worked with this last couple weeks where their loved one their partner is not doing well. And so they're not safe to be at home anymore. And so what do you do about that? And how do you manage to do that? And so I think if you show them the facilities, different facilities, and you can call our office and I'm happy to talk to you about which ones I think are good, because you want to keep people safe, right? And so you want the person who has Parkinson's to be safe, and you want the care partner to be safe too. So, and another thing, a difference between palliative care and hospice. Palliative care is helping you, your quality of life, and hospice is not to prolong death. It's to embrace it and to help you through that course to get to that point. So.
Great. All right.
Should I go ahead?
Go ahead. Thank you.
Thank you for taking the question, and thank you to Home Instead for watching my brother while we're here. That was really, really thoughtful of them. My brother just moved here from Hawaii, and we're trying to get him situated. One of the first slides that came up was startling, with the iceberg just showing the different symptoms, and he definitely is at the extreme symptoms that happen very infrequently. Incontinence and hallucinations and trouble eating and a lot of other severe things. And I'm trying to get a handle on, and a lot of this happened recently. So get a handle on what should we start thinking about. The hospice and palliative care have come up quite a bit. I don't think that he's in that position, but are you able to sort of anticipate when you have to be looking for those more extreme concerns? And this was, we think, more of a chemically induced Parkinson's. He likes a commercial farm, and so is exposed to paraquat and other pesticides. But that's my question. Thank you.
So with your brother, I think palliative care should start right now. Should have started when he was in Hawaii. And you moved him here. And so there's going to be some hiccups in how he's managing, because it's a big transition from Hawaii to Colorado. They're both lovely places. Colorado, now we have hopefully not too much snow, but palliative care, you know, I don't know do you have a neurologist for him? Not yet. Okay, so that's going to be the first thing, the first step for that. And then I've dealt with your mom, so give me a call and I can give you further direction with that.
If I may, I'd like to make one thing a little more concrete. It's a real dilemma for you and for me to decide when hospice is appropriate. There's research that shows that as few as 4% of people with Parkinson's, when they die, are receiving hospice services. And it's because it's hard to know when things are going to take a turn, because it's often some sort of event, a fall with an injury or a aspiration with a pneumonia. And so the rule of thumb that we learn to use is, would I, as the doctor, be surprised if this person passed away in the next 6 months? And if the answer is no, then let's think about, then the door is open to place a referral to hospice. So that's, I think, about as clear of a line in the sand as we have. And it's still blurry because we could still be off by years. So when I bring up the topic of hospice, I say, based on your symptoms, unfortunately, I wouldn't be surprised if you passed away in the next 6 months. Hopefully you've got longer than that, and we'll do everything we can to live as well as we can for as long as we can. But I'd rather get these services involved too soon rather than too late.
We're going to share a microphone. I want to add to this. That was perfect. It's good to know that if your doctor does recommend hospice, as he said, that nobody has a crystal ball. And really that 6 months is, if you think about it as like a goalpost, okay? And if the trajectory of decline and the falls and the infections and whatever's happening continues, then it's feasible that they'll meet that goalpost of the 6 months. However, you can sign on with hospice. Equipment can be brought in. Pain and anxiety and depression can get better managed. Quality of life might improve. When that happens, that trajectory of decline plateaus. The goalpost moves. In hospice, you're evaluated within benefit periods. If you go through an entire benefit period, which could be 60 days, 90 days, and there's no decline, your team's going to talk about graduating from hospice. People do graduate from hospice. And when that happens, there's a goal of care conversation of next steps. Do you want to try therapy again? What would you like to do at this point? Hospice then steps back and you're able to continue until you need hospice again. You can come on and off hospice indefinitely. There's no punishment for coming off. You can come off and then a week later need to go back on. We see different scenarios all the time. It's helpful for the doctors to say, you know what, I think hospice might help you right now, when they recognize there's a trajectory of decline. And it's helpful for you to know that there's not a crystal ball, but it also may not mean imminent death. So if that's any consolation too, that might be helpful. Another good starting point is palliative care, because the palliative nurse practitioner, she's going to know when hospice support is going to be more effective than just palliative support. You get much more support with hospice. So she might say, I really think you'd benefit from more support, and I'm pretty sure you would qualify. Do you want to pursue that? That's another good resource because they know both hospice and palliative. So those are some good ways to kind of think about that.
Okay, I think you had a question.
Yeah, hi, I'm Brenda Bronson, and my husband he's had Parkinson's diagnosed for 14 years. A thing that's always frustrated me is how he's tremor dominant. He has a lot of tremor, but I would think there's a more scientific way to measure it than asking him, when he's on and off, because he doesn't really know. And it seems like it's measurable, isn't it? Couldn't he wear something and it would hook to your iPhone, like your heartbeat and oxygen oximeter? And there is an answer there that doesn't have to depend on him with no chart, just telling you. I can see he tells you if it bothers him or not, but it'd be nice to know if the drug really does affect it and how that could be measured.
Yeah. Wearables in Parkinson's are an area of a lot of interest right now. And I think that's only going to increase. And so ranging from devices that you wear on the more affected wrist to a device that you set up kind of in the center of your home and you wear some sort of sensor that can detect how much you're moving around. These are not widely available currently, but it's an area that's evolving, because your point is well taken, which is sometimes it's not so obvious how the symptoms are acting for the 99% of the time that you're not in the doctor's office. Although it is still the case that if someone comes in with a wearable report that says, oh my gosh, you have tremor 80% of your waking day, and they say, yeah, but it doesn't bother me, then we still may not act on that information. Yes, but more information is coming.
And after your question, the person, Annie, there's someone back there who's had her hand up in the blue. We'll take you next. Yeah.
First off, I'd like to thank the panelists for being here today and sharing such valuable information. In an ideal world, private nursing would be wonderful, but kind of the reality for most seniors and people living with disabilities who are, they have limited resources, fixed incomes, that kind of those services are out of reach. Also kind of thinking about, co-pays, home modifications, durable medical equipment, the cost, it really just kind of adds up. And so I'm aware of like the Colorado Medicaid program that offers waivers. But do you know of any other alternative funding options for people on fixed incomes or limited resources?
Yeah, well, first of all, Parkinson's Association, we have equipment loan program. So if you need a walker or a U-step walker that is designed for people with Parkinson's, you can borrow that for 3 months to see if that works. So that's one thing. As far as getting resource funding, Parkinson's Association doesn't have extra money because we're nonprofit to give out, which I wish we could. And so I think you just have to, the people that are in between the middle, that don't have a lot of resources, financial resources, but don't qualify because they make too much money for things. I think if you can talk to friends, family who could help financially with that, that's another way to do it. There's just not a lot of resources to help with that. Depending on if you don't have a lot of money, you can apply through the social services to get additional help. If you're a vet and were exposed to Agent Orange in Vietnam, the VA helps 100% now for coverage. So I wish I had answers for you. I don't.
Thank you. I think my question is probably directed towards Jessica more than the other two, but you can all jump in. My experience with hospice in the past, when my mother-in-law was slowly dying, her physician was relieved of his responsibilities and another physician took over. Will that be the case with hospice and Parkinson's?
Are you talking about the specialist was relieved?
Well, her cardiologist as well as her primary care, they then provided, the hospice then provided her with a physician within the hospice community.
First, I want to say this microphone works way better than the one I had. Honestly, it varies based on hospice companies. Some of them, when they come on, they want to do exactly what you just said and just work with their medical director as attending. Our hospice does not like to do that. The reason is because your specialists, your doctors know your loved one. We're coming in brand new. So when we come on, we're going to ask your primary care physician, do they wish to remain as attending? And most of them do. Some of them are say, no, we'd like you to just go ahead and take over. So it depends. We take it depending on what the doctor wants to do. With specialists, that's a little different because the goal is not to continue, pursuing the curative anymore. However, If you're on with Parkinson's, you should still be able to go see your specialist for cardiology. So you're not on hospice under that diagnosis. So it's not a black and white answer, but generally based on the hospice company, you should still be able to see specialists outside of what your hospice diagnosis is. With Parkinson's, if we admit under that, what we will do is take all the recommendations from the neurologist and use those moving forward. However, there are some cases where we've consulted with the neurologist to say, what do you think about this? We try to keep them in the loop as a courtesy so that they don't feel like they've just lost this patient that they've built a relationship with for years. So it's a good idea when you're looking at hospices to ask that question. That's a very good question. And ask what's important to you is going to make your determination of which hospice you go with.
All right. I think we have time for one more question, and then we do want to leave time for the great discussion in the breakout groups. I know many of you have wonderful questions, and so please do jot those down. And then after this, you'll have an opportunity. You could ask those individually as well. So we'll do our one last question.
One of the things that I forgot to mention about hospice, and I haven't heard it with you either yet, and it's important, is the bereavement services they're provided afterwards. I know when I lost my husband, I lost the most wonderful person in the world to me, and I lost my purpose. And it's really hard to deal with all of that. So I think what you offer, and so could you tell us a little bit more about that?
I would be happy to do that. Thank you for bringing that up. It's a huge part of hospice is the bereavement programs. Our hospice, again, hospices may be different, look different with that, but I can speak to ours. We follow a family for 13 months. We offer resources when we identify high-risk families who maybe have children who are struggling. So we'll recommend them to, like Judy's house, for example. If there's a family member dealing with substance abuse because it's just so difficult for them, we have resources to direct them for additional help. In our office in Greenwood Village, we actually have a space that our social worker and bereavement coordinator will let families come in and actually have some counseling. It's all free. So there's a lot of different ways that we do support families with hospice. I also left a bunch of business cards on all of your tables. You can take a picture of it. My cell phone number is on those cards. Feel free with additional hospice questions to please don't hesitate to reach out to me because I'm the nurse educator and I will help to give you the information that might help you make informed choice.
We can do another.
Okay.
We can do a couple more.
Okay.
Yeah.
Thank you. My question or my dilemma is, and how do you draw the balance between a person who's falling all the time versus one who should be immobilized? I mean, my husband's been falling 5, 6, 7, 8 times a day. For 2017, he was first told he should stay in a wheelchair because he was falling. Recently he fell, hit his head, had a hemorrhage, and now he's in skilled care, totally confused. The dilemma then becomes, to what point do you sedate him or whatever option it might be to keep him from always trying to get out of the chair and falling? And it's a constant problem. And that's what we're dealing with.
I'm sorry for what you're dealing with. At the very advanced stages of Parkinson's, falling a lot and getting injuries from those falls, unfortunately, can be part of it. And there's not a good answer to what to do in terms of sedation. And unfortunately, sometimes you can talk till you're blue in the face about, please don't get up without me there to help you. And it's just one of the things that the disease will do is that people fall and they forget that they fall. And there's no way out of that puzzle. And so here in this now advanced stage, it's going to be a matter of comfort and trying to minimize those falls. But again, there's no, even if there's someone at his elbow 24 hours a day, it only takes a half second. So I think one of the messages for your situation and everyone's situation here is that there can be so much guilt as part of this disease. And at some point, we just have to realize this is a terrible disease. And we do everything that we can, and there's some things that we can't do, and it's not your fault.
Can I expand on that about it not being your fault? And I get a lot of calls from people who feel so guilty about when they're going to have to move their loved one to a facility, an assisted living facility, because we've lived together for 50 years and now things have changed. What do I do? And so you're doing what's best for your loved one and for yourself. And, there's when you get married or your spouse, your significant other, have to be PC correct with everything. But that, when you're up at you're exchanging vows with your loved one, do you say, I'm here for you when we're at retirement age and we're going to go traveling and do all these fun things that we've worked hard for. And now all of a sudden we have this chronic illness that's not going away. And it's not COVID that hopefully will go away. It's not the flu. It's not a cold. It's chronic. So I'm partnering with someone who has this condition that is going to progress. And what do I do? Do you want to do that? Do you want to have the crystal ball that says 40 years from now, our lives are going to be changed forever? So you did the best you could with your husband, and he's at a safe place now. And any of us, whether you have Parkinson's or not, you can fall. I got in an accident a month ago and I don't have Parkinson's. So it's what you deal with, what's in front of you. And that makes you who we are. Because I don't know anybody in here, you have this similarity that you have a family member that has Parkinson's, but we all have something. Nobody goes unscathed. So it's how you deal with what's in front of you that makes you who you are. So what I'm suggesting is that you, like Milena said, you are the heroes. Take care of yourselves first before you can help your loved one. Don't forget to breathe. There's not a copay with breathing. There's not a deductible with breathing. And so do things for yourselves first. And you guys did that today by coming to this symposium, and you should give yourselves a round of applause because you're here and you are not there with your partner. So give yourselves a round of applause and know that you are here for them and for yourselves. So.
And I'll just add really quick, when we deal with that kind of situation with a hospice patient, the goal is really to minimize injury from that fall. So with hospice, what we would do is bring in equipment. In a skilled community, he's probably already in a hospital bed, but making sure that bed is as low as it can be when he's in it is important. Having a fall pad in place is important. Possibly seeing about having the community do frequent rounds and checks might help. And then if you can afford it, hiring a sitter to sit bedside with him to try to distract and deter him when he tries to get up. Sometimes that helps as well. So there's different pieces to try to minimize the injury that can come. And then also assessing, why is he getting up? Is he in pain? Is he anxious? Does he feel like he needs to go somewhere? Is it just confusion? Some of those things can be fixed with medication, anxiety, pain. The goal would not be to sedate him to where he's just laying there. That would be a chemical restraint. Most communities wouldn't do that. We wouldn't want to do that. But if it's simply he's just anxious and restless and laying in bed is just driving him nuts, a little bit of Ativan may not hurt, something like that. So it's always good to talk to the nurses at that community or his physician to see if they can assess and see if there's something that can be worked on with that.
Hi. I'll get it out.